webinar on telehealth. And this week, I'm really excited. So we have two amazing presenters. I think all of you going to get a lot of just insight on these. So I have Aneel and Heather. So they've been the long term. I think for anyone who's been involved in telehealth, you probably see their name all over the place. So we're pretty happy to have them on our webinar. I guess maybe Aneel and Heather, maybe you could first just briefly introduce yourselves and maybe then dive in.
Yeah,
Hi,
everyone. Hi, everybody. Great to be on the webinar today. My name is Aneel Irfan. I am the founder and CEO of IMST Telehealth Consulting, along with my partner Heather. And also, a lot of you guys may know me. I am the contributing editor with Telemedicine magazine as well. So Milton's a great colleague and a friend, and we're looking forward to today's webinar to really talk about the nuts and bolts of getting paid for telemedicine and telehealth. I'd like to introduce my partner Heather as well. Go ahead.
Good afternoon, everybody. Thanks for attending. I'm Heather Zumpano. I am the project director and co-founder of IMST Telehealth Consulting. And like Aneel, I'm really excited to talk to you all today about value-based telehealth and how the payment models that are coming out are expanding the use and being able to get paid for telehealth. So here we go.
Thank you so much, by the way. So one of the reasons I'm personally really excited to hear your presentation, and I'm sure our audience is pretty excited, is so over the years, one of the number one questions we get asked all the time is about how to get paid. It's about payments, over and over again. So I think this is going to be just a super timely, and again, thank you so much.
And before I start, just a little disclaimer. We're trying to, we're going to give you a nice high level of the reimbursement in regards to telemedicine and telehealth. The traditional reimbursement when it comes to payers, Medicaid, Medicare, private payers. Also, we're going to give you a high-level overview of the value-based models that are being introduced, how telehealth plays into them, and what we really want you to get into the mindset of revenue. Also thinking about revenue models in regards to telehealth. So we'll go ahead and let Heather get started with the presentation, and we hope to have your questions afterwards.
Yes. And so getting right into it, getting paid for telehealth, that's why we're all here. That's what we all want to know. So this presentation, we will discuss briefly Medicaid, Medicare, and the Macro, quality payment program, private insurance, and revenue models. So reimbursement by the numbers for Medicaid, 48 states are reimbursing for live video or two-way real-time communication. 19 states are reimbursing for remote patient monitoring. 12 states reimburse for store and forward. 30 states use a transmission or facility fee. They'll pay for that. 29 states require a signed informed consent prior to a visit. And 2 states reimburse through their Department of Aging Services. And I would like to refer you all to the Center for Connected Health Policy website that you can use to find out where your current state, what your state is reimbursing for Medicaid. These slides are going to be available after the presentation, so you'll have access to all the links. So some more numbers for Medicaid. 28 states don't require a telepresenter. That means having a clinician at the patient's side to interface with the physician and the patient to assist the visit. 28 states don't require that. 25 states, they think that the home can be a originating site. 24 states plus the District of Columbia will reimburse for the care regardless of where the patient is located, at their home or at a clinic, without any restrictions. 24 states cover telehealth for state employees. 15 states plus the District of Columbia pay for any type of provider. And 41 states cover service statewide. And again, you'll want to check the Center for Connected Health Policy to find out what states, what your state is doing. But the reason why I'm presenting these numbers for Medicaid is to show you that Medicaid has really a lot less barriers across the board to reimbursing for telehealth services. And so that brings me into Medicare, where there is a bit of a contrast. Medicare They provide nationwide coverage under their Part B Medicare bundle of services, but the patient's home cannot be an originating site. And the guidelines are based on more traditional care models and very limited to health professionals that are in more rural areas or healthcare professional shortage areas. And they're definitely more restrictive on the care centers. So if the patient is at their physician's office or at a critical access hospital, federally qualified health center, skilled nursing facility, or community mental health center, those are just a broad list. But basically, I'm just trying to show you that Medicare has more restrictions on how they will reimburse for telehealth. But legislation is making its way through Congress to expand Medicare coverage and relax some of those barriers. And one of the bills that is having bipartisan support and hopefully will pass later this year is the Connect to Health Act. And we will talk more about that in just a little bit after the presentation. So the simple three-step process for billing for telemedicine services is to be sure that you're using your correct CPT code. And then the HCPCS code is your originating site. If you are the originating site, your facility code. And then most of the codes for telehealth are the same as in-person visits, but you just add a modifier, the GT modifier, and that lets the payer know that it was done virtually versus in person. And for the transmission or facility fee, if you live in a state that is a reimbursable service, then the code for that is Q3104. And without getting into too much detail about the codes, this link here will take you to all of the Medicare codes for telehealth services. So I want to cover Medicare and Macro because this is really the meat of what we're going to be discussing today. The Macro basically is doing away with fee-for-service model and moving into the value-based care. So there are two tracks that providers, if you have more than $30,000 in Part B charges for Medicare every year, and you have more than 100 Medicare patients in your community of care that you provide service to, then you will be required to choose, starting this year, one of two tracks. The two tracks are the Advanced Alternative Payment Model, where you earn an incentive payment for participating in an innovative model, which I'll go over in more detail in a second, or a Merit-Based Incentive Payment System, or MIPS, and that's a performance-based payment. But both are able to utilize telemedicine, whether it be live video, store and forward, or remote monitoring services to improve communication, to increase access to care, not only for patients and providers, but also for the members of the care team, to really bring in the patient-centered medical home model. So there are 7 categories of these incentive models to basically cover the whole continuum of care. The accountable care, episode-based, primary care transformation, initiatives focused on Medicaid and CHIP populations, initiatives focused on Medicaid and Medicare enrollees, initiatives to accelerate development and testing of new payment and service delivery models, and initiatives to speed adoption of best practices. So I provided this great link that I do want to take you to for a minute, where you'll be able to see all of the different models for the different categories of care. And what these basically are research studies. The part of the Healthcare Reform Act is to reform how healthcare is paid for. So you can actually sign up for any of these ongoing models that correlate with where you sort of live in the continuum of care. If it's episode-based, there's a bundled payment model, which they give you money up front to treat a patient. Basically, they're making an educated guess on how much all of the services and the provider's fees will be for patients over a 30, 60, or 90-day period after they're discharged from the hospital. And so you're able to basically provide the care, bill what your actual costs are, and then Medicare is able to compare it. But these are all research studies to really learn best practices, and telehealth is involved in these services through being able to have more frequent communication with the patient, reducing distance as a barrier, and also for patients to be able to monitor, or their care teams that come to them in the home when they're discharged from the hospital, to be able to record their vital signs and share it with the physicians and the medical teams to be able to intervene if any of the established parameters go into unsafe levels, basically. So after the webinar, when you have access to this, you'll be able to go in and research some of the models that are available. And then to cover the merit-based incentive program, what they've done with this is they've combined the meaningful use, PQRS, and value-based modifier requirements into one performance-based payment program. And they're giving the physicians, again, this is very fluid, and they're researching and they're working with providers to be proactive in these payment model definitions. They're allowing providers to set what their measures are and track the data that is pertinent to their discipline of medicine and report it to CMS. And physicians are reimbursed per member per month or on a per case rate for the services that they're providing. And the measurements basically are an evidence-based, and a lot of times telemedicine is being used for having virtual visits and, again, remote monitoring of patients' vital signs and their progress to basically have data that they can submit to CMS to say, hey, my patient got better and I saw them virtually. And so then you'll get paid for that. That's proof of your performance. So basically the quality payment program, CMS is encouraging providers and healthcare organizations to participate in the alternative payment model and merit incentive programs as research methodologies, as I said, to identify the future of healthcare payment reform. So you are able to go to the website that I just referred you to actually learn more about a program that fits your niche of service provisions, and either sign up for an existing program, or if you have an idea for a payment model, CMS wants to hear from you. And each year they post provisions for open discussion on each of these models before they get activated, and then those ideas that are shared get incorporated into the final rule. So I would highly encourage you to be the change you want to see, and you're not going to have a choice after this year. If you meet the qualifications, you're going to have to enroll in either one of these two tracks. So, get involved, be proactive, and there really are opportunities to use telemedicine to enhance care and really start to have an evidence base for improving care and the way you get paid for it. So it really goes hand in hand. As far as private insurance goes, 34 states and the District of Columbia have telemedicine parity law. Very simply, a parity law means that there is a mandate to have private insurers pay for a virtual visit the same amount as they would for an in-person visit. So this map, you can follow this link to the American Telemedicine Association website. It's always being updated as new parity laws are passed. And partial parity just means that they won't pay 100% as an in-person visit, but they will pay a percentage. And again, that is state-based to cover telehealth services. The top 5 commercial insurers that are reimbursing for telehealth across the country, even in states where there are no parity laws, are Aetna, Anthem, Blue Cross Blue Shield, Cigna, and United Healthcare. And if you do have credentials with other insurance companies, they're open to having you present them with a plan of how you want to use telehealth. And so, you just have to have a good line of communication with that payer and be able to, see if they'll give you permission to utilize those CPT codes with the GT modifiers to get paid for telehealth services. And the most fun, I think, are the revenue models, because then you don't have to get tangled up in all of the complicated payment situations if you're, with Medicaid, Medicare, or private insurers. These kind of give you an opportunity to be an entrepreneur as a provider and utilize telehealth in a business-to-business contractual sense. So the two revenue models on this page, institution to institution, is a monthly cost or a hybrid payment or a fee schedule menu where, say you're a private provider and you want to contract with schools so that they have access to a primary care physician or a specialist on demand via telemedicine, or a prison system to provide mental health services, or even as the next one is employer workforce. That's an institution-to-institution model too. Physicians can offer employers a primary care network, and the employer can have on-site kiosks or let their employees have access to a mobile application or even on their desktop computer at work to bring access to their employees. And services can be paid by an employer's self-funded health plan, out of pocket by the employee, per member per month, or on a case-by-case basis. And it's really great for employers because they can help reduce the number of sick days, which really does add up for over the course of a year. It keeps their employees well and their families, so they're also reducing time off of work for their children's healthcare needs. And two more revenue models that we're really excited about are the direct-to-consumer, and this is pretty well known with Teladoc, American Well, Doctor on Demand, MD Live. This is where patients pay out of pocket or use their health savings accounts. They can either pay a monthly subscription fee or pay annually upfront to access not their doctor, so to speak, but a doctor, whether it be a primary care provider or in a specialty of medicine. Usually the highest utilization for this is off hours, 2 o'clock in the morning. Your child wakes up with an earache, or you have some kind of, you're traveling on the road and you need medicine because you have a stomach bug, or you fell ill with some flu-like symptoms. So this is just strictly between a patient and a physician. And then the patient is able to give the physician that they see in this model permission to share the visit information with their primary provider to keep their medical record continuous. And then international agreements. There's a large demand for U.S. trained doctors in other countries, which presents great opportunities to contract with foreign governments, non-government agencies, and medical practices where there is not a lot of specialties. For specialists, this is really great. So there's a lot less legal barriers internationally than what we're experiencing here in the United States. So the global medical arena really can open a lot of doors and add a lot of value to improve healthcare around the world. And you are also, are able to generate another stream of income for your practice. So this is a high-level overview of what we wanted to discuss for the remainder of our webinar. And so we'll get into the questions and answers. I know, Milton, you have some questions for us, and then we'll like to field questions from the audience as well.
Terrific. Thank you so much for that great presentation there. In fact, we do have a couple of questions that are queuing up. By the way, for the audience member, please feel free to just go into the question section and post that. We'll get them queued up. I guess, Heather, so you talk about there's 34 states that has sort of telemedicine parity laws. Now, is there any limitation? Does that cover all the different specialties? And pretty much, if I get paid today for anything I do in there, I just need to add in the GT modifier, then I'm good in those 34 states.
Pretty much, yes.
Yeah.
To add on to the parity can be funny as well. The parity law has changed in several states as well. So sometimes parity could mean that it's the insurance provider decides how much of the parity they're willing to pay. So, for example, in some states it's mandated that they need to pay at 100% of what an in-person visit a doctor would charge. In certain states, there's loopholes where they can pay up to 50% or whatever they deem right. So what we're seeing also is, there's good parity or there's bad parity, so to say. And if you leave little loopholes in there, the payers will find a way to go through them. Now, I do want to add also, in states like, for example, we're in Florida. In states where there isn't parity, a lot of times us as providers, we throw our hands up as, oh man, we don't have any parity. They're not going to pay, right? What I have seen is if you're proactive and you approach one of your private payers with a strong plan, saying, hey, I want to cut ER admissions by doing consults from the ambulance or with the EMS. If you bring them a plan of how you're going to use telemedicine to cut your costs and show them the ROI, there is ways to work with your payers to configure your provider agreements to reimburse visits, even if there isn't a mandate in your state.
Nice.
So what I'll say is if there's states that don't have parity, don't just throw your hands up and say, hey, there's no parity, they're not paying. Go to your payers with a smart plan, and you can get your agreements configured.
Okay, really, that's really insightful in there. I think, in fact, what you described the parity, this is very exciting. I know from the 34 states, so one of the most frequent questions we get asked is on this special. It's just like even just figure out like how to get this done in there. I think that's really encouraging. I guess if you have, let's say, a provider who in one of these 34 states in there, if they're not currently a little bit confused in terms of how to exactly get that, is it as simple as just telling their billing department, look at the appropriate GT? Is it like as simple as that, where it's like?
It's tricky still, right? So one of the best practices that we've seen, and we encourage our providers, is call up your, double check, contact your highest, your payer mix and saying, hey, I want to contact my Florida Blue, and I want to make sure that XYZ telemedicine services are covered, right? And then you have to use those G-code modifiers. So it's really a little bit of legwork, right? Making sure you have your consent forms. Don't give them anything that may deny back, right? So it's important to have your consent forms in place, have good communication with your payers of what's covered, what's not covered, and also always inquiring. These things are ever changing. In the website, in the slides that Heather provided, the Center for Connected Health Policy is a tremendous website that I would encourage everyone to bookmark, because this site is always updated. You can jump in and have a map of all 50 states, maybe the states that you're licensed in, you keep an eye on, and it'll give you pending legislation, current definitions, all types of legislation in regards to telehealth policy. So that's a website that's a tremendous resource. And I would stay on top of it. You have to be proactive because the landscape is ever changing at this point.
Okay, excellent. So right now we have a question from the audience member, Jonathan. So he's asking, should we be using the GT modifier or the new 2017 modifier 95?
From all our research, the G-code modifier is something that's recognized. It's been used across the board. So I would use the G-code modifier until further notice, of course. And then also, again, I could go back to this. Make sure you have your ducks. Make sure you have spoken to your payers and they understand what telemedicine services are covered, what they want. It can change from payer to payer, So it's really important to really stay on top of that. From our experience and from our research, the G-code modifier is definitely needed. Because that shows that it's a virtual visit.
Excellent. So we have another question from Gregory. So he's asking, are the payers reimbursing for acute care and triage by telehealth to the individual providers?
That's a good question. Are you looking? Does he mean by more preventive care? Heather, do you have some insight on this?
For acute care, yes. Like, say that there's a rural emergency room and they have a patient that comes in. They have a telemedicine system that they can access, say, a trauma doctor from another place, then they can definitely, the trauma doctor can, be videoed in and assist the team that's in the rural hospital to take care of that patient, address their needs, and get them stabilized. And then, yes, they would be able to bill for that and get paid.
A lot of these Medicaid
accountable care organizations, there are models under the ACO category that I discussed that that incorporate that. But outside of just that model, from an institution to institution arrangement, that's one way for acute care to be taken. What is I wonder what his actual scenario is.
Right. And going back to what Heather said, it's important to understand when we're going back to those revenue models that Heather declared and presented, it's really about the providers starting to not only think about traditional reimbursement, but really think about how to deploy creative revenue models. So if that gentleman is maybe a group of ER doctors, right, and they recognize that there's a need for this rural hospital for ER coverage or trauma care, acute care coverage. So they can actually make an arrangement, just them, with this rural hospital to provide those consults. And when you look at that, that's just an arrangement. That's just a contract that you do. There's no reimbursement in regards to that. And so making those arrangements, developing those relationships, if you service them, well, you'll have those streams for a long time. So it's really about getting creative. If there isn't reimbursement, put a plan together, present it to these hospital execs. For them, it's going to be a lot cheaper than hiring someone on staff. Is that correct? So it's important to the reimbursement isn't there, not giving up on it, but coming up with a contract or an arrangement with that entity to fill that need. And so those revenue models, it's important to start really understanding them, working with your legal teams to develop the contracts that you can present these opportunities and servicing them well, so you have that revenue stream for a long time coming.
Nice.
Yeah,
Really.
another great example of the Telestroke for the acute care is Telestroke, where ambulances or helicopters can be equipped with the telemedicine equipment and then be able to plug into the interventional radiology team. So it's kind of an integration with the ER and the interventional radiology team, so that they can be communicating with the paramedics in transit, actually be able to see the patient, give medication delivery orders. I know that they're starting to actually carry the clot-busting drug, TPA, on these emergency vehicles to start, as long as the patient meets all of the right medical conditions. Yeah. But, they're able to have those relationships with the emergency medical services companies too, to provide that emergency intervention. Then as soon as the patient arrives, boom, they can go to the interventional lab and start getting treatment.
A lot of opportunities.
Yeah, excellent. We have another question from Dan. So he said, so there are some insurance carriers, specifically I think Anthem, that require you to use American Well's Life Health. So the idea is that if you do not use their platform, I think because they're an investor or major owner of American Well. So if you don't use their platform, they will not reimburse you in there. I guess the question is, do you see this approach where the payers are basically forcing to use a particular tool, or do you actually view this as something like an anti-competitive practice? It's actually illegal, be struck down by the court system?
Yeah, sure. You know what, at Milton, actually, that was something I was afraid of. I'm going to be honest, and I haven't gotten much clarity on that, so I guess it is happening since Dan is encouraging that. That is something that, as a ambassador for telemedicine and telehealth and the industry as a whole, I was hoping did not happen. Okay. Because I wanted providers. I was hoping that the providers had the power in deploying the telemedicine solution that they wanted to deploy, right? And that may or may not be a mandate. I don't know, and I'll get some more feedback on that. I'm not quite sure that a insurer can mandate and make the provider use their system. But if that's happening, I saw that trend starting to being incorporated when these partnerships started to get, official. So I don't think they can mandate you using their system. I think if you have a HIPAA compliant solution, you can use it for your patients. When it comes to reimbursing for their members, they may be able to mandate you to do that. So Dan, I'd love to get some more information on your situation, because that's something that I was very afraid of, and I guess it is happening.
Yeah, so I think evident that definitely I think American law are telling people like if you don't use our system, you're not going to get reimbursed. That's how I was questioning whether that's where like maybe anti-competitive or illegal.
Exactly. I saw that as a vision. I'm like, okay, so you guys are partnering up with these telemedicine companies. Are you going to make the providers use them?
Yeah.
What if they have their own systems? What if they want to use their own systems, right? As long as they're compliant, there should be some type of standard that makes it okay. So if that's happening, it's unfortunate, because again, I think that we should let providers really drive how they want telemedicine to be grown, right? And how they want to deploy it. That's one of the things that I think we made a big mistake with electronic medical records and EHRs, is we stuffed it down their throats. We didn't get their insight on how to deploy them, and we gave it a bad name. And so that's unfortunate. I hope there isn't any mandate that makes the insurance carrier do that. And that's something that I would be staunch on fighting. So Dan, I would love to hear more about that. That is something that I envisioned, Milton, and I saw that this could be a problem as these partnerships started to emerge.
Exactly.
Yeah, if I can add to that, Dan, either send Aneel or me an email at the address you see on the screen there. I want to talk to our telehealth attorney that we have a relationship with, because somehow that smells like antitrust law to me.
Yeah.
A little bit. Or Sarbanes-Oxley, like that skates on that line. So send us an email with your information. We will talk to him, to our attorney, and get back to you on that.
Yeah, because that would be good for us. That would be good feedback. That'd be good feedback for us and our clients as well. So thank you for that.
Thank
That's
you.
great. Yeah, in fact, I think we definitely, through our work on the street, we have a number of other cases. I think we could collect maybe even a class action lawsuit against something against.
Yeah, that just seems a little bullying. But yeah, go ahead.
Well, the next question we have is from Lisa. So she's saying it's like, again, so is there any ideas on how well the carriers are actually paying claims? We know that, I guess, the word on the street seems to be, when we go to the things like ATA and everything, they talk about, this parity law, all these things. But on the street in there, they still feel like there's still a lot of frustration. Do you feel like, are there, like, what's broken there?
The truth is, and I've talked to a lot of like revenue cycle management companies and kind of getting an understanding is how much of this stuff is actually being billed, right? And it's still very sparing. It's still, I think it still goes back to education. I think providers still generally don't know much about telemedicine. They don't know the general concept. They don't know compliance or legal. So even before the billing even happens, there's still gray areas on what they can and cannot do legally, right? And so, to go into the question, I think it's still sparing. I think when the reimbursement, what I've seen is if you have a strong relationship with your payer, and there is a defined model to your program, and as Heather would say, there's defined key performance indicators that you're doing this to cut costs and you're showing positive outcomes with your program, there is more of an ends to reimburse, right? So if you're just doing a visit here and there and there's not really a plan behind it, your payer is not involved, they're not inclined, because there's not a lot of mandates, right? So they're not inclined as much to reimburse. So where we've seen success and where we've seen the volume is when there's a healthcare organization or there's a group and they're actively engaged with their payer and saying, hey, we're starting a telemedicine program to cut down our inappropriate ER admission. And so we're starting a pilot here. We would like you to, work with our agreements to make sure these are reimbursed, because look what the counteract byproduct ROI is. So I think it takes communication with your payer and a defined program model for you to truly get these things. If you're just sporadic with it and you're saying, hey, I'm gonna get reimbursed for this visit, I don't really have a plan, I don't think that works as much, because there's no communication with the payer saying this is what the real value of it is. Like we said before, if you leave loopholes open for payers, they're gonna, hope there's no payers on the call, but if you leave those loopholes open, they're gonna jump through them, right? So it's important to have that open communication, understanding that this is the value a telemedicine program that I'm initiating is gonna solve, or a program or a problem it's gonna solve. That's how you get really paid for these visits.
Got it. Okay.
But I think that if I can add one thing, as I referred to the top 5 insurers that are advocating for telehealth and paying for it, I've been told that even in states where there's not a parity law, if you submit the GT modifier onto your CPT code when you are providing the service, that they're paying anyway.
Nice.
Even if there isn't, like in the state of Florida, for instance, Blue Cross, if you conduct a virtual live video visit with a patient and you submit the GPT code or the CPT code with the GT modifier, they're getting paid.
Oh, nice.
But I agree, and I will definitely, back up what Aneel says. You have to have the relationship with your payer. You have to empower yourselves, your organization, and your billing team to learn how to incorporate this into your daily workflow and maximize your reimbursement, because it's all potential money that you may be throwing away if you don't.
That makes sense. Now, can I ask you a follow-up question in terms of, at our last webinar in there, so we talked about there might be some legal gray area because there's certain cases, right, because you cannot do a patient exam in case, right? So from a medical perspective, whether is there any liability, you could do these telemedicine, well, there really should be in-person to in there. Now, in terms of, is there any gray area? I mean, so let's say you're in one of the 34 states. You actually, there is the parity law, but the medical condition you're treating there, since the patient doesn't have these sort of like medical devices or anything, you're really not able to examine. Now, in those cases, can you get, is it like okay to still reimburse for that, with not just a legal issue, you just need to call them into?
Are you talking more about doctor-patient relationship barriers, or are you talking about providing virtual kind of diagnostic exams and billing for those?
Diagnostic exam in there. So it's almost like, for example, if, let's say you're my doctor, I go physically in your office, so you have a lot of the equipment there to checking on me right then in there. But since this is telemedicine, so I might not have some of those things in there. Now, can you have a case where like there's parity law, but since you don't have the equipment there, you really should not?
I mean, listen, the consensus is you're still providing medicine. You're still practicing medicine, right? Mm-hmm. And so if there's a diagnostic test that is required for you to build this condition, and you're not doing that diagnostic test, whether you're not doing it virtually or you're not doing it in person, it's still wrong, right? So so that's important. When it comes to doctor-patient relationship, I don't know if you talked about that. There is still that barrier there in certain states where you have to see the person in person first. Now, I'm glad you brought up peripherals and diagnostic equipment, right? Because that's where I see the next step in telemedicine. Is we have the virtual visits, but I think as these offerings evolve, you're going to have to include diagnostic peripherals, equipment, and remote monitoring devices, okay? Because it's going to be, you're not going to, like you say, you're going to want to do the additional tests, and it's not going to be just primary care. You need to be able to collect those vitals. And so it's important to see the evolution as these programs, as your program evolves. Hey, maybe you started with mental health care, right? But as you grow your program, it's important to understand that you need to be able to do additional service lines down the road. These programs need to be touching people a little bit more. I see evolution in the remote patient monitoring market with the bill that Heather mentioned, the Connect for Health Act, but there's going to be a lot of reimbursement pushed behind remote monitoring, and also, like Heather also mentioned, tying telehealth reimbursement to these value-based models that we spoke of. So I think that Connect for Health Act is going to be a game changer for the industry. Has a lot of bipartisan support. It's going to be reintroduced. And it's the first time that we're putting telehealth reimbursement behind aligning with value-based payment models.
Yeah.
So what that entails is you need to have a more impactful program. It can't just be virtual visits. You have to start thinking about peripherals. You're going to have to start thinking about remote monitoring. And the best systems and the best providers and the ones that are going to have the most success are the ones that are going to have the best balance of those three: in person, virtual visits, remote monitoring, and the ones that have that good balance of all those things are going to be the most successful, I think, revenue-wise and impact-wise.
Nice. Okay. So I have a follow-up.
Oh, I'm sorry. I can't see you guys. So I just wanted to add to that is that patients can be provided with the technologies in their home, either because a lot of what your question asked would depend on who that patient's insurance is. Are they Medicaid? Are they Medicare? Are they private? That's really going to determine the level of reimbursement. But in order to conduct the visit, there are mobile cases, like briefcases that a presenter, say like a home health nurse or a physician assistant, goes to the patient's home and can interface with a doctor in a little tablet that comes in the briefcase. And like Aneel said, there's the peripheral scopes to help the doctor on the other end, you know, listen to their heart and lung sounds or whatever, listen to their pulse, just like they would in person. Another thing is if they are on a monitoring program, the patients are provided with like their blood pressure monitors or glucose monitors for, like for example, the bundled payment program. If they're going to be followed for 60 days and try to avoid readmission to the hospital for 60 days, they will be provided that equipment that they need for those 60 days to be able to either themselves measure and deliver those values to the clinician, or to have a caregiver help them to conduct those measurements and provide them to the caregiver.
We have like a follow-up question from Gabriel. So the question is, am I able to, so for these remote patient monitoring, am I able to bill for reviewing the reports or the data that's coming from these connected devices?
Well, it depends. It goes back to payer and what state you're in, right? In regards to remote monitoring, there isn't a real bill in regards to remote monitoring reimbursement. I think Mississippi is a pretty proactive state when it comes to reimbursement for remote monitoring. You can always look at that site. In regards to reviewing reports, one bill that we like to, that's very underutilized, is the chronic care management, which is not CPT code 99490, which is really just a per month, per patient reimbursement for follow-up activity with Medicare patients with 2 or more chronic diseases. So in this case, you can even have a staff member reviewing some of that data, and using telemedicine can help. Retrieve those reimbursements. So I would, for his question, going back to his question, you got to really check your not only what payers, but also what state. So, but I do know off the top of my head, Mississippi is a very proactive state in regards to remote patient monitoring, because that would go under a remote patient monitoring kind of aspect. And also kind of maybe even a store forward type of aspect reimbursement, which is less reimbursed around the country. But again, use the Center for Connected Health Policy, really review it, and I'm sure there is something out there in regards to reviewing data.
Yes, and the codes are pretty comprehensive too. I don't know if you guys can see this, that I have the list of codes up, and there are codes for, you know, actually providing care, reviewing information that is received. So
there you go.
I would say yes, if you are reviewing patient's information, just like whatever code that you would use to bill for reviewing a patient's chart, to be able to make clinical decisions and advance orders, you're just going to need to add the modifier to indicate that it was done remotely.
Okay. Thanks. So we have another question from Lori. So she's asking, so there are a lot of activity in the skilled nursing facilities in terms of impact, like the telehealth, like all these things. Now, what are the specific reimbursement revolving around Medicare coverage in the application of telemedicine for the skilled nursing facility?
So a great thing that happened in regards to skilled nursing facilities and Medicare reimbursement was they actually designated skilled nursing facilities as an originating site.
Mm-hmm.
So that was something that got expanded. So all the reimbursement in regards to telehealth that is under Medicare can now be originated from a skilled nursing facility. But the barriers that still exist with Medicare is you have to be a rural area as well. So there is still some barriers in regards to Medicare reimbursement, but including skilled nursing facilities as one of the originating sites that can be qualified does open up a lot of opportunity.
So as a clear, so you mean so even though it's qualified as a originating site, but if you're not in the rural area, then you cannot bill.
I mean, that's your biggest barrier when it comes to Medicare. So that's something that you have to look into and actually find out, are you in that area? One of the things that we've seen is usually the trend is that what Medicare does, everybody follows, right?
Yeah.
Medicare is like the progressive one. In regards to telemedicine, it's actually been opposite. It's been that the private payers have been more progressive, and the state agencies like Medicaid have been more progressive than Medicare. A lot of these Medicare, policies are very outdated. They were written when telehealth and telemedicine was looked at as something that's only viable for rural areas, and we all know that's not true. So there's a lot of movement ahead in regards to Medicare. We mentioned the Connect for Health Act. Another important factor of that Connect for Health Act that we all should keep an eye on is it's dropping the originating site barrier. And that's something that will open it up tremendously. So skilled nursing facilities, we took a step ahead, but there's still some steps behind. But again, there's something that you can look into. But all the Medicare CPT codes that Heather had shared, those are applicable to senior living facilities as an originating site to bill for them. So I will look at those codes, find out what your designations are, and go from there. But again, look at the private payers, look at creative models that you can deploy. Look at cost savings for skilled nursing facilities, guys. You can save a lot of money just for ER transportations, right? Yeah. So if you have a relationship with your local hospital, contact them. Say, hey guys, can you do an ER visit with us before we transport to save the cost? Yeah. In the end, that's win-win for both sides. You guys save costs for transportation, they save costs for inappropriate ER admissions. It's win-win. So it's communication. That's a starting point for a lot of skilled nursing facilities. That's some free advice.
Yeah, a great example of an institution-to-institution arrangement.
Okay, excellent there. In fact, I think we see a lot of activity in the skilled nursing facility. In fact, I think if you guys were to publish some sort of article about best practicing, like getting paid or business model, my hunch is going to be captured like a wildfire. Like everyone will be reading, knocking on your door.
And we're in Florida, right? We are in Florida. We are in the epitome of senior living and healthcare facilities. Now these are slow to adopt. They're corporate ran, so it's a tough movement. There's a lot of red tape when you come to these senior living facilities. One of the things that I'll say is telehealth will impact senior care the most. And the truth is that we have an aging population, we have rise of chronic diseases, and so all these tools that you're going to deploy in regards to telehealth, they're going to impact the senior care market the most.
Okay, so one thing, we are toward the end of our session there. We have so many questions queued up. I think of all the webinar we've done, this is the one that we have the most questions in there. And I think for the audience member, I apologize, we're not able to get to all your questions. But one thing what we'll do is we're going to pass these questions to the speakers, and then eventually when we publish the recordings in there, then the speakers, they will can answer some of the questions and answers through these. And of course, I definitely encourage you to contact Heather and Neil for specific question. They're just literally just, I'm so happy they're here. They're the expert on the phone.
Well, Milton, we do thank you very much, and I know this is a hot topic, right? But one of the things that we wanted to showcase here is you need to start getting creative with telemedicine. There's a real opportunity here to deploy your offerings, extend your offerings and your expertise in your communities, and it just takes a little bit of creative thinking. Yeah, there's barriers, but you got to start thinking about telemedicine as tools for not only where payment is going, but the creative models you can deploy now. So what I would encourage is, if you guys please connect with us. We're on LinkedIn, social media. Shoot us a line if you have any additional questions. And what we're also doing, because we love Milton so much and we believe we believe in the VSee product. So one of the things that we see, guys, is there's abundance of technology out there. There's tons of apps. There's tons of telemedicine platforms and devices and peripherals. What's really missing is people investing in technology before they invest in the program development. And so one of the things that me and Heather do with IMST is we focus on needs assessment, organizational readiness, developing a business case, finding out how you're going to get paid for your telemedicine services, and then fitting you with the right technology. So what we've done is we've created a special for everybody on the webinar in which you're going to get a discount on a VSee clinic. And I don't know how we agreed to this, but we're giving a free consultation for anyone that purchases that virtual care clinic. I believe it ends on April 25th. So I think everyone's going to get an email on that. But I would encourage you guys to take advantage of that. For any VSee customers that come off of this webinar, Heather and I are going to provide a first free consult to you to get you really your foundation of your telemedicine program off the ground, and that's exclusive to this webinar. So I would encourage you to take advantage of that offer. It's only going to be a month long, and provide you some, expert knowledge with some of the top technology as well. So I encourage you to take advantage of that, guys.
That's amazing. I definitely strongly encourage our audience members to take up.
We haven't done that with anybody else, Milton. So.
Having a free consultation with these two experts, that's just priceless. And we're back adding on top of 15% discount on top of the VSee clinic subscription. I think it's a combo. And then, Heather, I guess as you wrap up, I would like to maybe ask you the final question. So if you can whisper in President Trump's ear right now, ask him to, like all of this, of course, all the legislations having it, like, what will you tell him? Like, what would you like him to do in the that will have the biggest impact on industry?
Well, first of all, I would congratulate him on appointing Tom Price to be over Health and Human Services, because he is known to be a telehealth advocate. And so I would just explain to him that there are a lot of arbitrary barriers that are in the way in the access to care. And so if just like he's kind of chopping through a lot of arbitrary measures in other areas, in other industries, I think that I would just whisper in his ear, look, there's a lot of unnecessary rules and regulations in place that are preventing people from having access to good health care. And so if you can just do your best to eliminate those barriers so that we can get on and providing high-quality care, meeting people where they are, to reduce, especially geography, as a barrier and time, then we're going to save a lot of lives. We're going to save a lot of money.
Okay, I really.
And I'll add to that. I got a little bit of information. I went to a macro seminar just recently in Miami, and I had a lawyer from Washington that spoke, who was very close to not implementing ACA and now repealing it, right? And so one of the things that she said was parts of the ACA, like the macro and the value-based payment reform, that's not going anywhere. So entities should still be preparing for that. And telehealth and telemedicine, like Heather mentioned before, all those different tracks, in that language, telehealth is very complementary. And it's not written, plain sight telemedicine, telehealth, but attesting to those payment reforms, you're gonna have to use telemedicine or telehealth or these digital tools, right? So the value-based payment reforms are not going anywhere. So prepare for them. And she also said that a lot of these bills that now you actually seen passed, like recently we had the Project Echo, which is teleeducation passed. We have the FAST Act that's coming up with Telestroke. So we have a lot of them being passed. And she said because there's such strong bipartisan support behind these telehealth bills, those are expected to be reintroduced and expected to pass. So I don't see a lot of the repeal and ACA stuff really affecting the growth of telemedicine bills and legislation based on that. And the growth is going to continue with these emerging value-based models. So telehealth, for me, is business as usual. I think it's going to continue to grow. Let's continue to grow. And I would tell Trump just to leave it alone and let it grow. And really focus on getting rid of those barriers, like she said.
Excellent there. Again, thank you so much for this amazing session, Heather. And again, with that, we'll wrap up the webinar. Again, thank you so much.
Thank you very much, Milton, and thank you everybody for attending today. Have a good evening.